Our next presentation is by Dr. Richard Ahn, one of our residents, and his mentors are Sonia Bara and Lakshmi Ananthakrishnan. And Rich's presentation is comparison of Hounsfield units of pre-contrast versus virtual non-contrast images, feasibility study using novel dual-layer detection CT technology. Thank you.
All right, thank you. Thanks for the introduction. In addition to my mentors, many additional people were involved in the development of this presentation. These are our disclosures. So the objective of the study was to evaluate virtual non-contrast images generated from a novel spectral detector CT, enhanced phases on a novel spectral CT scanner compared with true non-contrast images. We hypothesized that these virtual non-contrast images would be equivalent to true non-contrast images. Why this is, we think, is potentially important is that virtual non-contrast images could be useful in evaluating incidental findings seen on contrast-enhanced CT, and also potentially reduce the dose in multi-phase exams where dose can be an issue. So spectral imaging involves both dual energy and spectral CT scanners. These are just really recently entering the clinic, and they allow materials characterization based on the linear attenuation coefficients of the materials being imaged. There are many potential clinical applications of these techniques, including virtual non-contrast images, which is what we're going to be talking about today. So this is the dual layer spectral CT scanner. There's a single source, and there's a detector with two layers. One layer detects low energy photons, and another layer detects high energy photons simultaneously. So through a single exam, you're able to collect all the energy you need, all the information you need to generate spectral data sets. This also can be done retrospectively if you don't want to look at spectral data for every patient. Other technology right now either uses a single source with dual rapid KV switching, or it's actually two CT scanners with two energy sources and two detectors. This is our study design. This is a multi-institutional study at UT Southwestern and Case Western University. There were 46 total patients, slightly more males. Average age was 62. A majority of these were multi-phase scans, and it yielded 84 pairs of true and virtual non-contrast images. All patients were scanned at 120 kVp. We divided the contrast phases into three different categories: arterial, portal venous, and nephrographic, and excretory. Those are the timings. And we measured mean attenuation in 1 centimeter ROIs in the liver, spleen, renal cortex, psoas muscles, subcutaneous fat, and in the abdominal aorta. Almost 1,500 ROIs were drawn, and subjective image quality was also evaluated for these images on a 5-point scale. So for statistics, we used equivalence tests to test whether the mean difference in attenuation between the virtual non-contrast and the true non-contrast images was less than 5, 10, or 15 Hounsfield units. And we used blind element plots to further analyze the data. So this is an example of some of the images that we used. This is the liver slice, and this is the kidney slice. The contrast-enhanced images are used to generate these virtual non-contrast images, and these are actual pre-contrast images without any contrast. You can see these are fairly similar. These green dots are the ROIs that we used. So all our virtual non-contrast images we were able to successfully generate. None were rated poor or unreadable, and attenuations differences of less than 10 Hounsfield units were obtained in 72 to 85% of cases. So this is a busy slide, but this is a lot of the data that we've collected. On this axis is the difference between virtual non-contrast images and unenhanced images, and these are the different sites in the body. For each phase, arterial is in red, nephrographic or venous is in blue, and urographic is in green. A majority of these tissues are within 10 Hounsfield units and close to no difference. However, subcutaneous fat is overestimated on the virtual non-contrast images by approximately 10 Hounsfield units. This is a table with the statistics from the equivalence tests for arterial, nephrographic, and urographic phase images. This is quite a busy table as well. What to look for is these red values are areas where the virtual non-contrast image was not equivalent at the various tolerance limits. So in a majority of tissues, it was less than 10 Hounsfield units. However, in fat, it was less than 15 for all three phases. To further investigate the attenuation of fat, we plotted the different virtual non-contrast related to the unenhanced images. We expect a one-to-one correlation if the virtual non-contrast images are working correctly. However, we see that the data points are shifted towards the virtual non-contrast, consistent with the increase at 10 Hounsfield units we saw in the other data. And it looks to be a systematic variation. So these are Bland-Altman plots of liver and renal parenchyma. Basically, on this axis is the virtual non-contrast, the difference between the virtual non-contrast and the true non-contrast. And on this axis, it's plotted based on the true non-contrast attenuation value of the liver parenchyma. The closer this data is to the closer to the mean average of the data is to 0, means it's an accurate measurement. For both the liver and the kidney, the mean is very close to 0. Most of the data points follow within 2 standard deviations of these 2 standard deviation lines of the mean. What to note in the liver is that at low attenuations, the liver attenuation is overestimated. We think that this is due to hepatic steatosis, and there's an error in the algorithm. In the kidney, we don't see this effect. We don't expect to see a lot of fat in the kidney cortex. And this is true, and this data includes the arterial, nephrographic, and urographic phase images. This is an example of a liver with a fatty infiltration. This is a conventional image. This is a virtual non-contrast image. Compared to the spleen, the hypodense area is more prominent on the conventional image than the virtual non-contrast image. And this is subjective image quality of the virtual non-contrast images. For arterial and nephrographic phase images, a majority of the scans were rated good or excellent. The urographic phase images were rated, over 50% of the urographic phase images were rated as fair. This was due to incomplete iodine subtraction. And we also calculated the potential radiation dose savings for non-contrast. We averaged the average dose for non-contrast, pooled enhanced phases, and the total dose, and we estimated that if we could eliminate the non-contrast phase from all these exams, it would yield an average dose savings of 32%. So the limitations of the study, we were using basically the conventional and the virtual Hounsfield units from the CT scanner. We don't have an absolute value of what is the true correct Hounsfield unit. We only looked at normal tissues, and we didn't look at the image quality of the source images used to generate the virtual non-contrast images. So any artifacts in those images could be propagated into the virtual non-contrast images. So in conclusion, virtual non-contrast images are similar in attenuation to true non-contrast images in most tissues. Subcutaneous fat was overestimated by approximately 10 Hounsfield units on all phases, and subjective image quality was reduced on the excretory phase images. And further study is needed to determine whether these virtual non-contrast images could be used to replace true non-contrast images, and whether attenuation values would need to be adjusted to determine whether a lesion such as adrenal adenoma could be characterized by this technique.
Questions for Dr. Ahn? Dr. Chopper?
Great work, very interesting. I have 2 questions. I'm wondering if the conventional non-contrast exam and the virtual non-contrast exam used exactly the same reconstruction, other than the fact that it's expert is nodding his head. So okay, so it's not a reconstructing algorithm issue. The second question is that, as you alluded to, things that are fatty are more prone to this bias, seems like, and for tissues or lesions that have variable amount of fat, it can pose an issue that probably needs to be resolved in the future.
Yeah, it definitely needs to be resolved.
This 10 Hounsfield unit appears to be quite a bit, but it seems to be, it's within 2 standard deviations. Did you guys look at, now if I have to get a virtual non-contrast image, would I prefer an arterial phase or a nephrographic or urographic? Which phase would I prefer?
The venous phases and the arterial phase seem to be both pretty similar in terms of quality and the attenuation differences. The urographic phase, the main problem was that there was incomplete iodine subtraction predominantly into renal collecting system. In areas where there's really high density of contrast, like in the aorta during an arterial phase, I think there's some issues with contrast subtraction as well.
Can you hear it? Yeah. When I was looking at the Bland-Altman plots, it seemed to me that the arterial phase will be good for liver and the urographic phase is going to be good for the kidney, the way I see the outliers, although the outliers are very small in number.
Yeah.
Let's take one more question. Dr. Allen.
Does the size of the ROI, is there like any cutoff for how big the ROI should be for the measurements?
So the ROIs we used we tried to make them 1 centimeter, except in areas where the structure was smaller than 1 centimeter, and we had to make a smaller ROI. The smaller the ROI, it's, I guess, less accurate because you're averaging less data.
Very good. Thank
Thanks.
you, Rich.